Okay, thank you very much, Raffaele. I think that we are only 5 minutes later to our schedule. So we can start with the second part of our conference, and I will ask to the speakers to keep in time, so 15 minutes, so that we can have the possibility to give to the people the possibility to do some questions. So I will ask Monica Kleinman to give her presentation. Monica comes from Harvard University in Boston. She's an associate professor of pediatric anesthesia and medical director of the medical and surgical ICU and critical care transport. Please, Monica.
Thank you so much. I'm going to make an effort to share my screen and hope that I'm able to do that, as I would like to show you my slides. I'm
sure that you will do that. Otherwise, we'll ask Riccardo Lubrano to help us.
Yes. I'm hoping that they will come up any moment now, because
they're coming.
Okay.
Very, very good.
I think I have done the correct clicks.
Yes.
All right. Are you seeing my screen?
Yes.
Okay. All right. First of all, I will make a disclaimer that I am not an emergency physician. I am a pediatric intensivist, but work very closely with our emergency department group and have gotten their input so that hopefully I am giving you the correct information about what is happening. I want to start by talking a bit about the epidemiology. As people know, now the United States has had a large increase in the number of cases, now representing up to a quarter of the cases in the world, and I think we are closing in on 1 million patients affected, with, as of yesterday, over 55,000 deaths. In Massachusetts, we have been recently called a hotspot, with 58,000 cases and over 3,000 deaths. In the city of Boston, there have been 6,700 cases and 315 deaths. And at my own hospital, we've had 58 cases and no deaths, fortunately, so far. As I mentioned, we're starting to show up on the maps as a increasingly drawn in color spot. Just below us, of course, is New York and New Jersey, which have had significantly more. And probably the area below New Jersey is Philadelphia, that Sage was just talking about. In between New York and Boston is Rhode Island, the smallest state in the Union, and they have had a recent significant increase of cases as well as deaths. In terms of my own hospital, we have 404 beds, of which about 1/4 are ICU beds, with about 20,000 annual admissions and about 60,000 annual ED visits. We're a level 1 trauma center and a regional poison control center. Boston is actually a relatively small city compared to some of the other cities in the United States. And so for our size, that number of ED visits, I think, puts us in what I would call the medium category. In the city of Boston, there are 4 institutions that hospitalize critically ill children that are shown here: Mass General Hospital, furthest to the north, Tufts Medical Center, Boston Medical Center, and then my own hospital, which is located toward the west of the downtown area. Early on in the COVID situation, 2 of these hospitals, Mass General and Boston Medical Center, closed their pediatric ICUs. And so now all critically ill patients who present to the emergency departments at those 2 facilities, which maintain their pediatric ED, are transferred to either Boston Children's Hospital or to Tufts Medical Center, so that we've become more of a regional referral center within even our own city. In terms of our pediatric emergency department, It is located within the main building. This area over to the right of the slide is the emergency entrance for the public to come in, and the ambulance entrance is on the other side of this building. There's no separate entrance right now for patients with or without symptoms of COVID. And what that reflects is that we are essentially assuming that everybody is a potential COVID positive until proven otherwise. And that has been something that has evolved over the weeks that we have been really iterating our procedures and trying to become as wise as possible, where we started very much with screening questions and trying to distinguish whether or not you were a suspect, and have evolved to everyone is suspected of having COVID until proven otherwise, in part because of the large number of asymptomatic patients that we know exist, and just our inability to predict which of these patients may actually test positive. We do still ask the screening questions that are common in all of our institutions. And the common ones that you see here are, I'm sure, familiar to you. If the screening is positive, the patient is put in a single room, and caregivers are given a mask. We do allow 2 parents maximum to stay with the patient, unless they are symptomatic, and in which case they're not allowed to stay in the building. This has presented a bit of a problem because there may be children who have only a single parent, and has really challenged our child life and social work staff to help when there's a need for someone to be with a child whose parent is symptomatic and is not allowed to stay. Many of our rooms are fortunately private rooms or single rooms, so we are able to put any patient who has symptoms into a private room. But again, with our approach, all staff are wearing PPE in every encounter, and every parent is asked to wear a mask as well, so that essentially we're following the same universal approach regardless of whether the patient has specific symptoms. We're fortunate that our lab was able to develop testing pretty early on. It is available 24/7, can be processed in as short as 2.5 hours, but the average turnaround time is about 5 hours. Just in the past week, we have gone to universally testing all patients admitted through the emergency department, as well as by our critical care transport team. And these patients get treated as a person under investigation until the test results are known for purposes of isolation, in other words, single room, as well as PPE. In terms of what we have observed, we've tested over 1,300 patients, of whom 58 were positive, and that's for a rate of 4.4%. Only 7 children have required admission to our ICU because of critical illness, and I'm going to describe them in just a moment. Of note, we've had 112 staff members test positive, and tracing for these so far has indicated all of those were community exposures as opposed to exposure in the healthcare setting. I think our clinical experience is similar to what people have been reporting. There's certainly the standard fever and respiratory symptoms with cough, pneumonia, and 2 children have developed ARDS. We've had 2 patients with myocarditis, one of whom required intensive care. We've observed that patients with both new onset diabetic ketoacidosis and existing diabetes, as well as ketoacidosis, have presented and been COVID positive without any respiratory symptoms. And we've also had several children tested preoperatively who presented with appendicitis who were positive, and that was their only symptom. The risk factors that we've observed, I think, are also common. Asthma and obesity in our teenagers, developmental or genetic disorders, other chronic diseases, immunodeficiencies and malignancies, 6 of our 7 children hospitalized in an ICU setting had significant comorbidities. Only 1 was previously healthy. As I mentioned, this is sort of the new look of everybody in the hospital wearing, depending on the specific circumstance, either N95 or regular masks for all care encounters. And certainly one of the interesting things we've observed is the kind of impact on care providers' ability to interact with children and their parents when their face is partially covered. But that's kind of a different topic. In terms of our ICU patients, we've had patients who are receiving mechanical ventilation, only 2 of them, 1 through intubation, 1 through a tracheostomy. We have treated several patients with non-invasive ventilation, vasoactive infusions. We've treated 2 children through compassionate use with remdesivir, and 6 of our 7 ICU patients received some form of immunomodulator therapy, either with anakinra or steroids, or in one case, eculizumab, which I have trouble saying. So thank you. I'm happy to answer any questions that you might have about our experience or our approach.
So thank you very much. Do we have a time for a couple of questions? So if nobody wants to ask question, I have a question. I'm just curious, who is paying the care of the patient that come to your hospital? Because you show pictures of very nice hospital, very nice housing. Their insurance paid for COVID-19 positive patients?
Yes. Early on in declaring the state of emergency in our state, essentially the governor ordered that insurance companies would pay for any COVID testing, and as well as any illnesses related to COVID. So most children have some form of insurance, whether it's private or public, and it is not always reimbursed well, but it is reimbursed.
Okay, thank you very much. So do we have other questions?